Alrighty, well, hello everyone, and welcome to another session of Virtual Global Spine Conference. My name is Ali Baaj. I'm happy to be hosting this this week, and also actually presenting as well on one of my favorite topics in terms of spinal intradural pathologies. I am accompanied today by a few folks here that I want to introduce. Of course, Dr. Mike Selby with us, who is one of the panelists. And today we have a special guest, Dr. Alwyn Gomez. So, so what we did is we thought we would emphasize the theme of this being engaging and interactive, as we like these virtual spine sessions to be. And we asked around online in the Twitter world, who, do any trainees wanna take the plunge and join us today on the spot and answer some questions? And I admire his courage, and he volunteered. We have never met. I don't know Alwyn. I'm meeting him for the first time today. So Alwyn, why don't you unmute yourself and just introduce yourself? Tell us who you are.
Great, thanks for having me. I feel like I'm the winner of a contestant in a game show or something. But my name is Alwyn Gomez. I'm currently a PGY4 at the University of Manitoba in Winnipeg, Manitoba, Canada. And I'm currently also doing my PhD here as well, out of the Department of Human Anatomy, in some research mainly focused on cerebral autoregulation and traumatic brain injury. I'm originally from actually the eastern coast of Canada, in a place called Halifax, Nova Scotia, and I kind of have a dual interest both in spinal surgery and in vascular and skull-based surgery. So intradural kind of pathologies are kind of a nice overlap of both of my interests. So it should be cool.
All right, very good. Well, thanks so much for joining us, and welcome again. I promise I won't pick on you too much, but we do need to keep this interactive. So welcome, Alwyn from Winnipeg to the program, and we're joined, like I said before, with Dr. Mike Selby and also Dr. Nader Dadale, who just joined us. Welcome, Nader.
Hi, how are you? I'm looking forward to this session. One of the best speakers is Ali Baaj with about intradural tumors. It's going to be beautiful.
You're very kind. You're very kind. Okay, so we're going to go ahead and get started. Again, everybody knows what the format is. If you have any questions or comments, feel free to put them in the chat box. Otherwise, I'll go through some cases, and some of them we will discuss among the faculty, and others I will put our guest resident, Dr. Gomez, on the spot. So we're going to give you a pass on the first one, Alwyn, just so you can warm up and see how this works. This one, I will engage my good friend, Dr. Dadale, with this case. And for the participants who are joining us, I have to apologize. A lot of you have seen a lot of this online and different platforms. Everybody knows I like to share cases and share knowledge, but perhaps we can inject now the technical nuances, the complications, and really bring 2D pictures into 4D, if you will, with the engagement and the discussion. So Nader, this is a 18-year-old male who presented with neck pain and early myelopathy. His family really didn't think much of it until several months later, when he said, "Hey, you know what? My hands are really getting numb." And finally, he got an MRI of the neck, and this is a contrasted MR and a T2. Sagittal, as well as the axials. What do you do with this?
So obviously, anytime we look at imaging that shows a spinal tumor, we want to put this tumor into a compartment, because the compartment that the tumor belongs to will generate the differential diagnosis, and that's important. So extradural tumor, usually it's a malignant, either metastasis or multiple myeloma, sometimes primary bony tumors too, which are not malignant, but usually an extradural compartment would speak to more of an aggressive type. And an intradural extramedullary tumor, which is in that compartment, would dictate the differential diagnosis that includes a nerve sheath tumor, which include Schwannomas and neurofibromas, as well as meningiomas as another. Now, this tumor obviously belongs to the intramedullary compartment, and usually the tumors that belong there, the age group would definitely, dictate the differential diagnosis. But in this instance, you see a homogeneous tumor with an associated syrinx spanning multiple levels. In that age group, and with this imaging, you would think of an ependymoma as the number one in the diagnosis. Less so an astrocytoma, which is another intramedullary tumor, and less so a hemangioblastoma. So ependymoma comes up to my mind. It's homogeneously enhancing. It's almost always associated with a tumor, with a syrinx. And usually for these patients, I would also image the neural axis totally, the brain, cervical, thoracic, and lumbar spine, to also rule out drop metastasis or dissemination from elsewhere. So that's my differential: ependymoma number one, then followed by astrocytoma, and then a hemangioblastoma.
Yeah, that's absolutely perfect, Nader. You're absolutely right, and that's a very nice way of laying out the different types of lesions that occur intradurally. So you're right. This is an intramedullary, intradural intramedullary. I always had a problem with that classification because by definition, if it's intramedullary, it's going to be intradural. So the bottom line is this is a spinal cord tumor. And so Nader, to help me and help Alwyn as well as the participants, you're going to take this kid to surgery. Here are the levels. You see them. He's symptomatic. What would you do technically for him? What type of procedure, what type of fixation, if any? And what would you tell the family are the risks of significant deficits after surgery from removing this large spinal cord lesion?
So absolutely. I mean, this is, I would definitely tell the family, this is a serious problem. Most likely it's a benign tumor, but it's a serious operation with potential neurological deficits that may occur following resection of any intramedullary tumor. And also the issue with post-laminectomy or laminoplasty kyphosis, because to get to this, you need to do a multi-level decompression. In this case, an attempt at a laminoplasty would be ideal, to be honest, than a laminectomy. In my opinion, fusing them up front, I don't like doing that. It adds too much time to the case, and you're not guaranteed that the patient will end up with kyphosis, but the risk is substantial, like maybe 75%. So I would tell them we'll attempt at a laminoplasty, and then certainly it's a dorsal approach. So you put the patient in pins, prone on a open Jackson table, arms tucked. You want to do pre-flips, obviously. Neural monitoring, get some baselines and make sure that you maintain them, and make sure that the patient has an arc line and the mean arterial pressures are maintained above 75 or 80. You want to make sure that the cord is perfused. Neural monitoring is key in that in the procedure, and get pre-positioning, and then you flip them prone, and midline incision. You gotta decompress above, throughout, and then below. You want to make sure that you're totally above the tumor and totally below it. And then you open up the dura, and you would try to do a midline myelotomy here. I think it's pretty much midline. I don't think there's, maybe it comes to the surface a little bit to the touch to the left side. I'm not sure, but if you see it, if it comes to the surface, you can definitely follow that. But usually standard midline myelotomy, you're going to expect some decrease in the SSEPs that you should not be super concerned about. And then you work your way out. That's a laminoplasty here. Now the thing here, gross total resection, you ideally want to remove it en bloc if possible, because that would probably give the patient the best chance as a cure, as Dr. Ali Baaj did here clearly.
Great points. So see, Alwyn, it's not that hard, right? You just have to replicate just what Dr. Dadale, who's the residency program director at Northwestern, did. But that's exactly right, Nader. So I showed this case, and in full disclosure, this was in my previous practice. I did this with one of the phenomenal pediatric neurosurgeons. We tag teamed this case together. It was in fact an ependymoma. I feel that, and gross total resection, we know is often curative in these cases, of course. And I've always had, mixed feelings about laminoplasty, right? So I think historically, especially amongst, I would say, our pediatric neurosurgery colleagues, in my personal opinion, I think there was just this kind of understanding that, hey, the laminoplasty would prevent kyphosis, right? I mean, that's why I think it's ingrained in our training. And I think that could be, that could be true. And certainly he wanted to do a laminoplasty. He asked me to help with that. I said, that's fine. I guess especially for lesions that cross the cervical thoracic junction, I tend to do the fusion up front. And I know he's a young kid, so, you really have to weigh both options here. But this is a little bit self-promoting, but 5 years ago, we put together this neurosurgical focus edition on pediatric spinal deformity. And this was one of the great papers from the group from Johns Hopkins, where Mari Groves is there now. Dr. George Jallo was there for a long time. And, I don't know many people who did more pediatric spinal cord tumors than he has. And this paper looked at their case series of laminoplasty versus just laminectomy. And they found that basically there was no difference in terms of which patients end up having deformity after, and about 15% needed a fusion from that total group. So the discussion was interesting because, yes, many of us, I think, and many surgeons out there would probably still offer a laminoplasty after a multi-level laminectomy, especially in the growing spine, right? In a pediatric patient, in a patient who's still growing. I would say personally, once that patient reaches skeletal maturity, I would have no issue offering a fusion up front. It certainly is a lot easier than coming back later to scar and having to do a revision fusion. But the point of this case is, yes, this is an ependymoma. So Alwyn, there you go. Dr. Dadale laid the scene for you, and he showed you how it's done, and now you're up. So this was I believe this was a female. I want to say she was in her 50s, and she came in with paresthesias, intermittent numbness and paresthesias from the waist down. I'm only giving you one picture. My colleagues here know me. I like the mid-sagittal T2 or the mid-sagittal T1 with contrast. That usually tells me a lot. So Alwyn, what do you think when you look at something like that?
Yeah, so here we have this mid-sagittal cut, and obviously it's beneficial to have the actual intraoperative imaging as well. So I think I have a bit of an advantage here, but it seems to be a gadolinium enhancing intramedullary lesion, identified here to be at the level of T8 without significant cranial or caudal expansion. There doesn't seem to be an associated syrinx in this situation, and no obvious other lesions. Kind of different to the previous lesion, the extent of gadolinium enhancement, and it's on the imaging or on the actual image of the tumor, it seems to be coming to the peel surface. It maybe increases the possibility of this being a hemangioblastoma, slightly higher than, say, an ependymoma in this situation, but I would still put that on my differential. Other components that would be on this differential would be an astrocytoma, given its enhancement, potentially even and depending on the age of the patient, potentially something higher grade. I think those would be kind of my top two in this particular situation.
Perfect. So you're absolutely right. So Nader laid it out for you. Again, you know, for obviously you said you're a PGY4, you already know this. For a lot of the trainees that are with us, like you said, when you see something intramedullary, you will have to make sure, of course, it's not transverse myelitis or an MS plaque, but let's just put those on the side. We think it's a tumor. It's going to be one of those three things, right? Statistically speaking, you always want to play your odds. Hemangioblastoma, astrocytoma, ependymoma. Now, I'm going to ask, before we get to what we did, Alwyn, I'm going to ask you this. I'm also going to ask Nader and Mike Selby. Sorry, Mike, I'm going to pick on you. I know you're an orthopod, but still, these days there are no excuses. And I also want to ask the audience, everybody who's with us, if this patient had back pain, 50-year-old female, you know, has some back pain, didn't get any better, neurologically intact, and they get this MRI and it shows this. Alwyn, would you proceed? Would you operate? Would you say, hey, you know what, you're intact, let's just watch this? Or would you say, oh boy, you know, this looks bad, it's big, we got to take it out, or at least biopsy it? Alwyn, what would you say? And what would the colleagues in the audience say?
Yeah, so with, you know, if you went through the imaging and you're fairly confident that this is going to be an intramedullary mass lesion, and like you mentioned, we've eliminated, possibilities such as multiple sclerosis or transverse myelitis. I think there are benefits to going in and doing surgery up front. I think in our practice here, what we generally tend to do is go and get a diagnosis from pathology. The other thing to consider is, even though there aren't any hard neurologic deficits, that oftentimes, you know, with intramedullary tumors, the best indicator of post-operative neurologic function is going to be preoperative neurologic function. And so I think, you know, waiting for this to either enlarge or result in a hard neurologic deficit may put this patient at kind of undue risk. That would be my opinion and my approach.
Yeah, no, that's fair. That's very thoughtful. Mike Selby, what do you think? I mean, in terms of patient comes in, back pain, incidental finding, obviously this is, you know, a spinal cord lesion, but you know, the general idea of how you treat a patient who's intact with an incidental finding, what do you think?
Yeah, look, I mean, there's always that risk-benefit equation, isn't there? Because you can do harm taking this out. But yeah, I think that just goes to a more general comment that, and I think most of us who've been in spine a while know this, that thoracic pathology can drive lower back pain. You know, and so I think it's always, you know, in the classic, you know, missed ED one is the thoracic epidural abscess presenting with lower back pain, right? But, you know, I suppose the question here for me is, you know, is this driving some of the pain anyway? And is that enough then to completely justify taking it out? Not just the point that Alwyn made very well about, you know, if someone comes in with this known lesion and is neurologically deteriorating, you know, you've done them a major disservice perhaps by not taking it out beforehand, as we know what the predictors of outcome can be. So yeah, I think I'd be looking to one of my great colleagues here and assisting them on taking this out. I like assisting, but not being the primary surgeon for these ones.
Yeah, very thoughtful. And you're absolutely right. And this is going to come up later with some thoracic cysts causing back pain, radicular pain, flank pain, and you know, sometimes that's as disabling, although not as dangerous as myelopathy, but certainly disabling. Luckily for us, maybe not so much for the patient, but luckily for us, the patient was symptomatic. She did have numbness, tingling, and we discussed just that. We discussed the risks of, you know, waiting until she's myelopathic, or going in there and resecting this lesion, realizing that it's probably an ependymomas. And if you respect the planes and you don't rush the surgery like I'm showing here, of course, this is you know, this video is not in real time. You usually do have an excellent outcome. And I'm going to mention this in the end. I don't know what colleagues think. You can certainly put in the chat or not, or I'll ask you. You know, I'll never promise any patient, and especially not this patient, that, oh, your numbness is going to go away or your tingling is going to go away. In fact, it may worsen a little bit, but on the flip side, we hopefully will save you from having an ataxic gait or having weakness or paralysis. So there are certainly serious risks with this, but I think if they're done successfully for the right indication, you're preventing worsening of neurological deficits that this tumor is going to grow. Nader, your thoughts on that? How do you approach these lesions in patients who are mildly symptomatic but have an obvious quote unquote scary spinal cord tumor that is benign, but let's say they're mildly to minimally symptomatic?
Well, that's as everyone mentioned, and Dr. Selby articulated it really, really well, and you did too. I mean, it's if the patient's asymptomatic or has only back pain, because we're not sure resecting the lesion is going to help with the back pain. There are a million causes can definitely explain it, but you can't guarantee the resolution of back pain by resecting it. So usually if the patients are totally asymptomatic, they have a stone cold exam, risk benefit, I would definitely entertain both options, but I would lean towards watching it with close follow-up. We're not going to wait for it to cause major symptoms, but any sign, any new symptom, even if it's just numbness or tingling, just any symptom, that neurological symptom that indicates that the lesion explains it, I'll pull the trigger, because the preoperative neurological exam predicts the post-op exam. If they come in a poor shape neurologically, the outcomes are not good. So, but the dilemma is in asymptomatics. You're only exposing them to risks, right? Like, what is the benefit if they're totally asymptomatic? What I would do I would definitely close follow-up and make sure that any increase in size will pull the trigger. Any new mild symptoms will pull the trigger. In terms of surgery, I mean, that's kind of my philosophy. It's just, to me, it's hard to justify operating on someone who's stone cold asymptomatic. If they're minimally symptomatic neurologically, yeah, absolutely, because they're symptomatic, and this will progress. But if they're like incidental findings, and then they come to you, I'll just watch them closely. I get a scan after 3 months, and then see if it grows or it doesn't, or how it behaves, because we don't know how long this lesion has been there, right? Like in patients who are asymptomatic.
Right. Yeah, that's very well articulated. I think that's the hardest thing is you see an MRI, you see this lesion, was this lesion there for 2 years, for 3 years, or 3 months, right? I mean, we know it wasn't a week, but it could have been there for 5 years like that, and it could have been stable. So it's always hard because we have only one snapshot in time. But that's great. So of course, I'm showing you the case because the patient did well, but we're very lucky that she did fine. Alwyn, back to you. What do you think of this MRI? Patient comes in with significant lower back pain.
Yeah, so this one's a little bit different than the ones I think we've been talking about before. It seems to be more of like an anterior based lesion. From my view, it looks like it possibly could actually be extramedullary, but obviously it'd be nice to scroll through some of these. So I do think that this may fall into the category of an enhancing extramedullary intradural lesion. So top of the list for me would be a meningioma possibly, although no obvious dural tail that I can see here. But yeah, maybe would like to look at more images, but that possibility of it being an extramedullary intradural lesion.
Yep. Okay, that's perfect. You're right. Some of these can be difficult, especially when we're just showing 2 cuts. And this turned out to be an intradural lesion. It's closely, it's very intimately associated with the conus. It's at the distal part of the thoracic cord. Give me 1 or 2 things that this could be now that it's intradural and it's really right there by the conus.
Yeah, so other kind of extramedullary or conal lesions, especially in this location, you'd think of maybe a mixopapillary ependymoma in that situation. Yeah.
Perfect. Yeah, exactly. And you're right. This could be a schwannoma, it could be a meningioma, it could be metastasis. But anytime you see an intradural enhancing lesion at the level of the conus, you have to consider a mixopapillary ependymoma. And you're a neurosurgical resident. So this is a fair question for you. What's so unique about a mixopapillary ependymoma histologically and oncologically, if you will?
So I guess oncologically is a broader question. Histologically, it has both myxoid and papillary features, hence its name. Oncologically, it does have a predilection to actually recur and seed. So I think actually in the most recent WHO classification, they changed this from a grade 2 lesion to a grade 1 lesion to a grade 2 lesion because of its predilection to seed and then recur. And so I think they emphasize removing this en bloc with minimal disruption of the actual tumor cups.
Yeah, absolutely. Those are excellent points. So for a long time, this was considered the only grade 1 ependymoma. So the other ependymomas that I showed you are benign, but by definition, they're grade 2. This one, was classified grade 1 for a long time. And you're right, pathologically, histologically, they can differentiate which type it is, but it used to be the only grade 1 ependymoma, although it's benign, just like the other ones. And you're right, this is a nice midline laminectomy, resection of the lesion. This is the one lesion, as opposed to the other one, for example, where it was in the mid-thoracic cord. I would say lesions around the conus are probably the ones that I almost always tell patients, you're going to have short-term bladder issues. You may need to be, to use a catheter for a few weeks or hopefully not a few months, but most of the time we get lucky and they have zero neurological deficits from these, but occasionally that the bladder is just so sensitive to these, and I just always prepare patients. Luckily, knock on wood, I've never had somebody who had long-term, requiring catheterization, but I've had a few that they needed, they went home with a catheter or they needed to be straight cath for a few weeks. By 3 months, virtually all of them do quite well. All right, Alwyn, that was great. So we're gonna move forward a little bit. This is a lady in her 60s who presented with a known history of breast cancer. Okay, she's got a known history of breast cancer, and she's been complaining for a few weeks of more than that, actually, several months of lower extremity subjective weakness, difficulty walking, and they find, they get imaging and they see this lesion. Alwyn, what comes to mind? And I know I'm not showing you all the studies, but this is a T1 with contrast. This is a T2. What do you think this could be?
Yeah, so there seems to be some extensive cystic components to this lesion with kind of a nodular component of contrast and enhancing nodule there. It raises more of a suspicion of possibly an astrocytic or kind of glial tumor based on kind of the intramedullary nature of it. There is always that, rare possibility of this being actually more of a, intradural met, but I would put that much further down on my differential.
Perfect. Yeah, I love what you just said. I think it's so important, and I think I should kind of reiterate it just so others hear it as well. Yes, metastatic intradural mets is on the differential, but it's certainly low down. It's not as common as we think. We'll see it once in a while, but more often than not, these intradural lesions, intramedullary lesions are something else, even in a patient with cancer. So yes, they could have metastasis, they could have drop metastasis, but certainly medulloblastoma in young patients is a common one, but these tend not to be metastatic lesions. Nevertheless, the patient was symptomatic, like you said, a lot of cord swelling there. So we took her to surgery, and let's see. Well, you got to know what the diagnosis is before the video, but this was the diagnosis: hemangioblastoma. And we did not know that until we got in. And the reason we didn't know that, this was kind of, let's explore it, let's open the door and see what we find. And some of you have seen this video a few times now, but this is what we found. And this just did not look like a metastatic lesion, right? This looks like a hypervascular lesion, a large draining vein here. And so I actually, I'm not a vascular neurosurgeon, of course, but I am a spine surgeon, and I love to tackle almost all the spine cases. This is probably one of my favorite lesions, and I'll tell you why. It's it's a tumor. It's a benign tumor, number one. Hemangioblastomas are by definition benign tumors. Patients do well. They tend to be peel, right, Alwyn? So they come to the surface. By definition, they're peel-based lesions, and they're not high flow. So you can be aggressive with cauterizing and basically isolating that tumor. Everybody has a different technique. I put the bipolar down to about 10 or 15, circa, just like I would, sometimes with a cavernoma. And then I would isolate it and then take it out en bloc. So it's a very satisfying lesion to take out because it tends to be peel, it tends to come to the surface. So the reason I show this case is because, just because a patient has a history of other cancers, common things are still common in the intradural space, right? Which is the spinal cord tumors that we talked about, and then the intradural lesions. Metastasis is a lot less likely. This one, I'm going to give to Nader. He may or may not have seen this. I'm not sure. Nader, this is a gentleman in his 50s who presented with significant myelopathy. And this was long-standing. It was over several years. His workup for MS was negative. His neurologist referred him, and they said, hey, in discussion with the neuroradiologist, we're concerned that this is some kind of intrinsic tumor. What do you think, Nader?
It's intramedullary, obviously, and hence the differential diagnosis. What's common is common. You put the diagnosis. So
I'm sorry about that. I put
okay.
the diagnosis.
Well, thank you. So what's concerning about this is when you see a lot of cord signal change like this is like edema, right? It's not a syrinx, it's actually edema. Then that kind of makes you suspicious of things beyond like an ependymoma. Ependymoma usually is syrinx, polar syrinx above and below. Hemangioblastoma, hollow cord syrinx, right? Sometimes. And then astrocytomas, they're cystic, right? Solid cystic, the grade 2s, right? But when you see edema like this, then, vasogenic, then you think of sometimes of a higher grade. Doesn't come at the number one of the differential. So here the thing that what one should do, I mean, what I would do, sorry, not should do, one would do, you do the laminectomy, and then you gotta biopsy the tumor, right? Like you now, because it's so high grade, achieving gross total resection here versus a biopsy is probably debulking. Like the goals are different. Like it's an ependymoma, you got to take it all out, right? If it's a high grade astrocytoma, you don't. You can debulk, take a biopsy, close things up, and then radiation post-op, because the prognosis of these is pretty bad. Like a GBM, an intramedullary GBM in the spine is just, the outcomes are poor in the months. Yeah.
Yeah, no, absolutely. Sorry that I gave away by mistake the diagnosis, but so this case taught me a few things. I did this relatively early in practice, and I said, hey, the vast majority of spinal tumors are benign. So I told the family, hey, I'm very confident this is going to be a benign lesion, probably an ependymoma or a low-grade astrocytoma. But you're absolutely right. And Alwyn, I think you heard what Dr. Dodley said, which is when you have something, this large, it looks infiltrative. Now, you really should start out with a biopsy, confirm that it's benign, confirm that it's not a lymphoma, for example. So we did that. We did a laminectomy, we did the biopsy, and then it took a while for the results to come back. I think the pathologist was probably as surprised as we were. And honestly, there was an excellent plane, believe it or not. And I was confident that this was going to come back as an ependymoma because it was just, the plane was great. And I said, wow, this is, just like any other ependymoma, I guess we just got lucky, and the guy did great. They could not tell me what it was from the frozen. They said there is, gliosis, there are tumor cells, but they can't tell what it is. I told the family, hey, I'm pretty confident that this is going to come back as an ependymoma. and it 100% came back as a grade 4 malignant astrocytoma. And I felt absolutely terrible. And I said, wow, I can't believe I have to go back and tell the family that this is actually pretty malignant. I hadn't seen one since, but obviously it is reported. I mean, they're rare, but they are reported. It was almost like a true GBM of the spine. And one of the questions from Dr. El-Helu is, would you consider more resection than a biopsy with 5-ALA? You know, I don't have a lot of experience with 5-ALA in the spine. Obviously, our cranial-based colleagues do a lot of it, and they're getting very good at it. I think it's very reasonable to start implementing that more regularly in the spine for spinal cord lesions. But I think the classic teaching is biopsy, wait for the result. If it's malignant, you know, you really don't want to start getting into normal tissue, and because the treatment is going to be more palliative, chemotherapy, radiation therapy. So yes, common things are common, but you've got to be, you know, once in a while you're going to see these. And what I learned from this, Alwyn, is just, you know, give the patients the statistics and what the likelihood is, but never promise them benign or malignant until you get the pathology. So that made me feel bad. And this is just a follow-up case. I'll move through this one quickly. This is a follow-up case that emphasized that concept that I just mentioned, which this was a young lady in her 40s, I believe, early 40s, who just came in with some left thigh numbness. Her left thigh was numb, and the lumbar spine was relatively unremarkable, as you can see here, but she just had this strange appearing intramedullary lesion. It looked like it was exophytic. I think we even did an angiogram, and it was not a vascular lesion. And we decided to explore it, take a biopsy, see what this thing is, take it out, you know, maybe a hemangioblastoma, but certainly this T2 scan here looks a little suspicious. It's just a little bit more infiltrative. And it was not a very pretty tumor. It was peel-based, but it was very stuck. It was very firm, did not have great planes, was not vascular. And it turned out to be actually a primary melanoma of the spinal cord. And one of the fellows back then, I think, tried to get it published. I don't know if it ended up getting published or not, but I know he wrote it up and did a great job with it. But it was a primary melanoma of the spinal cord. So technically, it was a cancer of the spinal cord. And again, these two cases kind of taught me to just be careful when you talk and counsel patients about what the pathologies could be before you go in. Nader, did you want to say something before?
Yeah, I mean, I agree. I mean, the frozen section, most of the time, they can't give you a diagnosis, to be honest. And the question is, like, as you mentioned, you have a nice plane, patient's doing okay, signals are okay, and you feel it's an ependymoma, you got to continue, right? Like, I mean, it's, if you don't, because rarely you would, even if they gotten back to you on time, they would never give you more, just unlikely to give you a definitive diagnosis. They say we're going to run some few stains, we see abnormal cells, right, like glial based, but up front at GBM, it's just tough. So yeah, I mean, yeah,
Exactly.
Continue. Yeah.
We'll bring it back to what's the more common pathologies that we all see, thankfully. Alwyn, this is a chip shot. Okay, I'm going to throw you an easy one here. So no pressure, right? So this gentleman came in with myelopathy and arm weakness, right greater than the right greater than left. What do you see, and what's your differential?
Yeah, so starting with kind of the compartmentalization, looks intradural, extramedullary in this situation, seems to be eccentric to the right in the posterior aspect. When we talked about extramedullary intradural tumors, you know, Schwannomas and Meningiomas come up. This one's almost certainly a Meningioma based on two things. It doesn't seem to have any extension into the neuroforamen, and it also seems to have a pretty characteristic dural tail, both cranially and caudally.
Yep, excellent. You're absolutely right. It looks like it's avidly enhancing. It looks like it's a discrete kind of lesion. It's got that dural tail here above and below. And luckily, this is right here under the lamina. It really does not significantly involve the facet joint. And we're going to talk about when, when we fuse and when we can get away without a fusion in these cases. But this is a case I'm comfortable doing without a fusion, honestly, just a laminectomy, 1 level, maybe 2 levels. I'm a little bit, I think now my incisions are smaller and my lames are smaller, but I used to give myself ample exposure when I started doing these. But you're absolutely right, Alwyn. So this is a meningioma, grade 1 meningioma. Of course, we know that meningiomas can be also atypical or high grade, but the vast majority of them are going to be low grade. And I believe that, yeah, this was that case. As you can see, a generous lami for good exposure, and you really should be able to get a very good resection once you take down the arachnoid planes. And you somebody once, I heard this a long time ago, they say meningiomas are basically tumors of the veins in the brain. It's not necessarily untrue in the spine either. There's usually a lot of vasculature that feed these meningiomas, and as long as you skeletonize them gently, you should be able to get a good total resection. Questions that come up with these meningioma resections, and they have before, I think, in other presentations, is do you resect that dural tail or not? Do you put a patch? What is the chance of recurrence? And there are few studies out there, I don't believe any of them is quite recent, that demonstrate that these spinal meningiomas don't have the same recurrence rate as the cranial ones. And so for me, again, risks, benefits. I prefer a nice watertight, closure of the dura, no CSF leak, than, oh, let me take a big piece of dura out, patch it, increase the surgical time, and potentially create, a porous or not a watertight closure. So I typically, if I can, I close the dura primarily, and I avoid taking any significant part of the dura. So Alwyn, this is gonna go back to you, this case. So same like last case, large enhancing lesion, very, very well demarcated. You can even imagine, or you can even see a dural tail, right? Yeah. So let me ask you this. This was a gentleman who obviously had severe spinal cord compression and significant lower extremity weakness. How are you going to approach this lesion? What are you going to do? How are you going to take it out safely?
Yeah, so this lesion, we don't have all the cuts, but there's a possibility. I still think, even though you mentioned the dural tail, there's, I think, a pretty strong possibility it could be a Schwannoma as well. So you want to be able to explore it laterally. I think in this situation, you'd be prepared to obviously start with a laminectomy at this level, but prepared to do a costotransversectomy to try to get laterally and explore that nerve root out laterally to get full resection. At the thoracic level, you wouldn't be as concerned about having to resect the root.
And if you do that costotransversectomy on the right, let's say this is T6-7, I really don't remember exactly which level, but let's say it's T6-7, you do a costo on the right, you didn't touch the left. Are you going to offer an instrumented fusion, or are you just going to do a wide laminectomy, costotransversectomy, and not fuse?
Yeah, I think you could probably, maybe we're more conservative here. I think I would probably not fuse and just allow it to see if there's any follow up and see if there's any deformity that forms later on. But kind of unilateral in the thoracic spine, I think you allow yourself to be a bit conservative there.
Okay, yeah, that's great. Those are great answers, and you're absolutely right. And we talked about this case before at a previous session, or maybe we had a conversation on Twitter with some of the colleagues. But your answer is the correct answer. It's the safe answer, and certainly once you get asked whether on the boards or any other venue, you're absolutely right. You're going to get a CAT scan. I usually get a CAT scan if I think it's a meningioma, just to make sure it's not calcified, because that does affect things. This was not calcified. yes, you don't want to manipulate the cord. You want to go as lateral as you can. In this case, either transpedicular with a facetectomy or a costo, so you can just, remove the lesion really without manipulating the cord. And I think you would not be wrong if you say you do a short segment instrumented fusion versus mid-thoracic spine. We're not going to offer significant instability. I'm just going to watch. That's okay too. But I think the key is to say you're not going to do a midline laminectomy and reach around that cord and take it out. So you're right. What I did for this, and again, it's just because I've done a lot of these in the sense that I'm getting a little bit more comfortable and doing less bony work. But yes, I did what you said, and partly I did the LAMI. I did a pseudo transpedicular partial facetectomy, not a complete costotransversectomy. So really minimal disruption to the facet. And because I realized this was going to be a soft tumor, I knew that we could take it out without the fusion, right? And so that was the selling point to this patient, who was offered a extensive decompression and fusion or resection and fusion, which is not wrong. But once you do enough of these, you kind of get a sense of how much pressure you can put on the cord, how much the cord will tolerate. And we were lucky enough to be able to remove this without a fusion. But you're right, it's a meningioma. It certainly could have been a schwannoma. We have a few minutes. I'm going to talk about schwannomas because everybody loves those. They're a lot easier. But this is what comes up is, do you patch or not? Do you resect the dura? Do they recur? I personally don't patch a lot of these, and I think the incidence of recurrence is quite low. And I really enjoy a very tight kind of watertight closure. I think that's very important. Before I go to the next case, I'll ask Mike and Nader. Dr. Burchuk is asking about an endoscopic techniques in tumor resection. I'm not aware of any endoscopic intradural work yet. I mean, obviously the world of endoscopy is taking off, which I think is a great thing for our field. Our colleagues are doing, endoscopic T-lifts, decompressions, laminectomies. I'm not aware of any intradural work. Can you guys answer to that, or do you know any colleagues who are doing it?
Minimally invasively with a retractor, we've done a few meningiomas and nerve sheath tumor, but in my opinion, like endoscopically, I'm not aware, like endoscopy, but minimally invasive with tubular retractor. I think with these intradural tumors, the goal is to maximally safe and maximal resection, watertight dural closure. So these things, at least in my hands, are open cases. Now, going back to instrumented or not instrumented, I agree. Like most intradural tumors, even the ones that are midline and ventral, you can get to them through a dorsal approach, or like a laminectomy, medial facetectomy, as you did, and they rarely require a fusion. Not 100% of the time, but most of the time. Once you talk about extradural tumor that are ventral, it's hard to get to the midline without resecting enough bone that would destabilize the spine, and these ones that you usually would need reconstruction. But intradural tumors, you rarely need, even the ones that are ventral and midline, like ventral in front of the spinal cord. There's always a corridor that you can utilize to kind of debulk and then pull it away from the spinal cord safely.
Yeah, I just want to check with Ali and Nada. If you guys do have to instrument these now, would you use carbon fiber implants so you can see better on an MRI for follow-up? Because, they're not often grossly unstable. You may get away with, the carbon fibers over titanium-based implants. You guys got a comment on that? I mean, is the recurrence rate, and I don't know this as an orthopod, but is the recurrence rate high enough to justify using carbon fiber? Like, do you need to just keep MRIing them, or what's the situation?
Nader, what do you think about that?
For tumors, my colleagues have used a few times carbon fiber instrumentation for the purpose of improving resolution for follow-up. but it's hard to detect hardware failure with those two. It's like pick your poison. But yeah, it's advantageous and in the context mostly of metastasis, like for an intradural tumor that are mostly benign, that are, you need to watch them, but the likelihood of recurrence is not as high as metastatic tumors or other primary tumors that are not resected en bloc. Then just go with titanium with metal suppression sequences, because you're not instrumenting that index level. You're still able to see with the metal suppression techniques, I think, enough. But again, for these specific tumors, intradural ones, you rarely need to instrument. There's always a corridor, and you don't have to be super liberal with one resection. It's just a laminectomy, medial facetectomy, as Dr. Baaj did. You can get down to the midline and remove them. Like even CSF leaks, for instance, ventral CSF leaks, I don't have to instrument. You open up the dura, you go a little lateral, and then you can get to the midline pretty much easily.
Yeah, I agree. I agree with that, Nader. I think these are just so benign and so slow growing and recurring. I don't know if it justifies the potential cost of the carbon fiber implants, and I agree that's more really reserved. I think carbon fiber implants are great for primary bony tumors. The chondrosarcomas, the chordomas. Those are the ones where you really want to find out, even if they recur a tiny bit, because that changes the plan. But typically not for these. Great question, Mike. All right, we've got time for a few more cases. So we're going to stay on the meningioma theme. These are, I really like these cases in particular, because I think it's really where the skull-based folks and the spine folks, neurosurgery, the cranial folks and the spine folks meet here at C1, kind of foramen C1, C2. So this is your classic kind of foramen magnum / C1, if you will, meningioma. And it was funny because when this actually was from this last year. And, if you call it a foramen magnum meningioma, right, the cranial colleagues are going to take it. But, we said, oh, no, this is a C1 tumor. So we ended up taking it. But again, I really like this. There's a lot of beautiful anatomy there. And Alwyn, this as a neurosurgical resident, you've got to do just a little bit more work there. You've got to navigate around, in the next picture, I'll show it to you, but you got to navigate around the pica, the vertebral artery. And again, one of the most common questions is, do you need to fuse? And in my opinion, the answer is no, you don't need to fuse. We used to do a lot of C1, C2 dumbbell schwannomas and neurofibromas. Again, you don't need to fuse. The more we're understanding where the stabilizing ligaments are, where the joints are, just because you do a C1 Lamy, you don't need to fuse the spine. And of course, our colleagues who do a lot of Chiaris know that. So this was a meningioma. This actually was a schwannoma that had come up from C2. This is the C2 foramen here, the C1, C2 foramen, and it came up. And I'll mention why I like schwannomas in a minute. But again, this is a nice view of the vertebral artery, the pica. I don't like to see that a lot, but once in a while, I'm okay with it. So those are fun cases that again are just kind of really, you have to fine-tune your microsurgical skills a little bit. And finally, Alwyn, I'm going to send it back to you. I can tell you this MRI is from the internet, so it is not it's not this case, but it could be this case. Alwyn, what do you think this is? Let's say it's a gentleman with lower back pain. The MRI is from the internet. The video is my video of my patient. But let's just say it's a middle-aged man with a lot of leg pain. What do you think this is?
Yeah, so you could have a few things here. It could actually be a droplet from an ependymoma. Could be a schwannoma reaching out, or a meningioma. Probably either, I would say, is that the associated histology?
That is the associated histology. If you can read a histology slide, I certainly can't, but yes, that is a histology.
No, I would put, it doesn't look, that doesn't look like an ependymoma to me on histology. So maybe a Schwannoma.
Yeah, exactly. So it's Antony A's and B's. So by the way, Alwyn, you probably haven't seen a spinal meningioma down at L4-5, have you? You might have, but I don't know.
A spinal meningioma, you said?
Yeah, unlikely,
No.
right?
Well, yeah, I haven't seen one.
Yeah, exactly. It's very rare, right? We're not going to really see probably an intradural, meningioma down there. More likely, these are schwannomas, right? Very avidly enhancing. And I always tell people that these are our favorite cases because, patients tend to do very well. They tend to come off sensory branches, right? Sensory rootlets. So you do intraoperative neuromonitoring, you stimulate, you cut the afferent rootlet, you cut the efferent rootlet, and you just kind of, boom, take it out. It's certainly one of the most satisfying types of cases. So yes, you are right. This is a schwannoma. We like schwannomas. They're virtually always benign, and they're pretty easy to take out. And this, for your histology class, or for those folks who enjoy it, it's the classic Antony A and Antony B's. But we'll skip that since I'm not an expert on histology. One last case here, and I was hoping we could get to the other fun stuff, which are the cysts, spinal cord herniations, and spinal arachnoid webs, but that's going to have to wait for a part 2. Alwyn, this case just demonstrates what we talked about before, which is this is a ventral lesion. It is complete. You'll see the axial in a minute. It's completely ventral, but it certainly did not look like a meningioma. It did not have a dural tail. So we were confident it was a schwannoma. So therefore, if you know it's a schwannoma, you know it's going to be soft. It's not going to be necessarily very firm or tenacious like a meningioma. And I just want to show you this video. So it's quite ventral. As you'll see here, it's enhancing, it's ventral, and this is what Nader was talking about. If it were extradural, it'll be a little different, right? It's hard to get there without doing a significant facetectomy or maybe, a costotransversectomy. But although this is completely ventral, and when we showed it in conference, some folks suggested doing a ventral corpectomy. I'm very confident that you can get these through the back. The key is, and I'll show you here as the video goes, you've got to be a little bit liberal with I'm going to stop it right here. So obviously the spinal cord, the dura is tented on one side. You have to choose your side, right? You're going to cheat to one side or the other. So in this case, I don't recall, maybe it was the right side. You do a partial facetectomy like we did early on. You don't destabilize the joint. So this patient is not going to need a fusion. And like Nader said, if you take down the dentate ligaments and you're a little bit liberal with sacrificing some thoracic sensory rootlets, which I'm not going to lie to you, I kind of do quite frequently. There's so much overlap with the thoracic nerves that patients rarely feel that, but that really gets you a beautiful corridor there, lateral to the spinal cord. And the second thing is you just have to get comfortable with how much retraction you put on the spinal cord. So I'm not recommending Alwyn that you necessarily advocate this or do this. Your answers are correct. You want to do as much bony resection to take the tumor out safely, but once you do enough of these, you get a sense of how much kind of traction and pressure you can put on the spinal cord without any issue. But I like taking these lesions out in block. This was a schwannoma because I know where they start, I know where they end. I'm not messing around with bleeding there. So I think it's really helpful to take them out on block if possible. So again, schwannomas, we absolutely love schwannomas for that reason. I apologize because I've been talking a lot, and I literally have the second half of the talk, but that's going to wait for another time. That's cysts and spinal cord herniations and CSF leaks. But we'll stop there since we do like to stop on time. Alwyn, I want to thank you very much for being courageous and stepping up to the plate. We've never met. There's a world stage out there, and probably hundreds of people are going to watch this on YouTube. You did a great job. So congratulations to you and your mentors over there in Winnipeg in your training program. I hope you found this to be okay.
Yeah, it was really great, and thanks for having me. It's awesome to have an opportunity to learn from some real stars in the field, so it's been really good.
Great, absolutely. Nader, Mike, any final thoughts before we close off today?
I just want to congratulate. Yeah, go ahead, Mike.
Oh no, just learning for me, refreshing. I feel like an R1 in this, right? So.
Alwyn, congratulations. You did an amazing job. You're an R4. This is pretty impressive. So you should be proud. You're definitely courageous. That's not easy to do, and it just very well. You articulated everything very well. Differential diagnosis is excellent. So definitely you did supremely well. So congratulations to you and your program.
Yeah. Thank you. Thanks so much, Alwyn. Folks, next week is Dr. Koithan is hosting, and he's hosting one of his colleagues from Duke Neurosurgery, Dr. Isaac Karikari, who is a spinal deformity surgeon trained with Dr. Lenke in Columbia. So we'll, just to compensate for this session, next week is going to be all T2 to pelvis, screws and rods. But we look forward to seeing you all then. So thanks everyone for joining us today. Have a safe week, and we'll see everyone next Thursday. Thanks, guys.